Morning, everybody. So I'm Peter Wayne, and I'm the research director here at the Osher Center for Integrative Medicine. And I want to invite you all to this first installment of a new format for our Grand Rounds, which from here forward will alternate monthly between research Grand Rounds and clinical Grand Rounds as you've seen it in the past. I have the distinct pleasure this morning of introducing our speaker, Dr. Ather Ali, who I think is uniquely qualified to launch this integrative medicine clinician researcher Grand Round series. Dr. Ali is an assistant professor of pediatrics and general medicine at the Yale School of Medicine. He's also director of the Yale Adults and Pediatric Integrative Medicine Clinic, and he's a busy man. He's also the director of the Integrative Medicine Program at Smilow Cancer Hospital at Yale New Haven. Dr. Ali is somewhat of a pioneer, being one of only a handful of naturopathic clinician researchers that are highly successful in the U.S. today. After receiving his Bachelor's of Science degree in psychobiology at UCLA, Dr. Ali attended Bastyr University, where he received his degree in naturopathic medicine. To build his research skills, he then received an MPH in epidemiology, as well as a master's in science of health in patient-oriented research, both at Yale University. Part of this training was supported by a prestigious NIH K23 Mentored Research Award. Dr. Ali's research interests are quite diverse, ranging from fibromyalgia, chronic pain, and cancer to irritable bowel syndrome, the microbiome, and the physiology of nutrition. His work's been funded by lots of grants from the NIH and other foundations, and he has an impressive and growing resume of peer-reviewed articles on this work in noteworthy journals. His talk today is slightly different than what I wrote down, and it's Individualized Diets in Irritable Bowel Syndrome, a randomized controlled trial. So without further ado, please join me in welcoming Dr. Ather Ali.
Thank you, Peter. That was very flattering and certainly an honor to be here amongst friends and colleagues. And thank you, Helene and Darshan and the whole Osher group. And so happy to talk. And so I'm going to talk about a study we recently finished and some of the thought that went into it and sort of why we did it and the results. And hopefully we'll have time for discussion at the end. And so as noted, we have grant support from the NIH, from the Wallace Research Foundation, Basic Biological Research, and Cell Science Systems. And I'm currently on the Scientific Advisory Board for Basic Biological Research. I know I will be discussing investigational uses of a commercial product because that was the clinical trial we did, so I can't avoid that. So a little bit about irritable bowel syndrome, and any clinician here will tell you it may be bread and butter for integrative medicine clinician. In general, functional somatic syndromes, or what now the Rome 4 criteria calls disorders of the brain-gut axis, tend to be highly common in integrative medicine practices. The previous diagnostic criteria, what we used for our trial, was recurrent abdominal pain or discomfort for at least 3 days a month in the last 3 months associated with 2 or more of the following, including improvement with defecation, onset associated with a change in frequency of stool, and onset associated with a change in form, meaning the appearance of the stool. This criterion fulfilled for the last 3 months with symptom onset at least 6 months prior to diagnosis. And here discomfort means uncomfortable sensation, not described as pain. So the Rome 4 criteria, which was published in 2016, simplifies this by noting that it's pain only, not discomfort, starting over 6 months ago and being 1 day a week. About 11 to 14% of all people are diagnosed with IBS, mostly females, and in the United States, IBS and its sequelae cost $1.5 billion direct and indirect per year. 60% of patients with irritable bowel syndrome report that their symptoms change with their diet, whether or not some foods exacerbate symptoms or improve symptoms. And there's many unvalidated methods out there to assess food sensitivity. There are many commercial labs marketing blood tests, for example. The gold standard to assess food sensitivity, which is a real contrast to a true allergy, a IgE-mediated allergy, where you have immediate hypersensitivity, something like peanut allergy, food sensitivity sometimes can manifest in skin problems, eczema, rashes, headaches, etc., nonspecific symptoms. The gold standard to assess this is a double-blind, placebo-controlled challenge, oftentimes putting foods in capsules and assessing people's reactions to them. That's certainly cumbersome and happens very rarely outside of academic context in terms of studying these things. So the clinical dilemma, which we often see in integrative medicine practice, is patients come in with these sort of nonspecific symptoms. They believe that food has something to do with it, or the clinician has an inclination. And the question is, how do we assess this, right? So one is an elimination challenge diet, which many people incorporate, where people eat a restricted diet for a period of time and then gradually introduce foods that people often are sensitive to. Oftentimes culprits tend to be things like wheat and dairy and soy and citrus and things, but these diets can be quite elaborate and challenging. They do work well, but self-reports about adherence are problematic. So patients don't often know exactly what they're eating, especially if they're not preparing or cooking their food at home. Sometimes the ingredient lists are long in packaged foods. Sometimes they can just eliminate common foods, but that may not take care of a potentially offending food, so call it a shot in the dark. Blood tests. There are many marketed out there, and there's lots of fanciful claims, to put it at best, amongst companies offering these tests. But in general, none have been independently validated, though patients tend to like them because they come with these very colorful charts, and people, we often have patients bringing them in and showing, look, I'm sensitive to this, and I haven't been eating that for 3 years, but nothing's changed. And, it's upset my diet at home, and my children can't eat this. And so it creates a lot of difficulty at home, sometimes with no clinical validity. And then there's many other alternative diagnostics marketed in the integrative medicine world, but in general, very few have any scientific basis to them. So a couple of years ago, we did a survey amongst integrative medicine practitioners around the country, asking them about what sort of unconventional diagnostics they use, if any. And by and large, if you see the third row down, the food allergy and intolerance tests, especially in children, tended to be the most commonly utilized. And in the context of doing this survey, one of the manufacturers of one of the tests, the ALCAT test, came to us and said, would you be interested in studying our product? And that took me back, and I was like, are you sure you want me to do that? Because in general, it's one of many that I was semi-familiar with, but I've never utilized clinically, but sort of lumped them all in the category of these sort of unvalidated, highly marketed tests. And so the response was, yes, in the sense of we'll do an independent, rigorous study, but no matter what we see and find, we will publish this, and are you okay with this? And the answer was yes. And so that's how we studied this particular test. And so the ALCAT test, what we found in our survey, some people said that it's of greater clinical value than IgG tests, which have some interesting research. Many studies are negative. Some studies show some benefit in headache, for example, removing foods associated with IgG elimination diets. The test is commercially available. The general technology is it cultures peripheral white blood cells with like 200 or 250 different food extracts and is incubated for a period of time. And then using flow cytometry, looking at changes in the morphology of white blood cells, and based on that, the foods are classified as sensitive or non-sensitive. So that's the technology used. And this is a typical readout of that test. So a patient, when they send in their blood, they'll get back something like this. So the red is what's called severe intolerance. So these are foods that have the greatest morphological change. And orange, moderate intolerance. And then the green, for example, are things that have shown no reaction. So patients get these things in the mail, and then they conform their diet to this. So taking a step back, you often hear in the practitioner world, how can you study individualized care. I treat it individual. I don't do cookie cutter medicine, right? Well, I see a lot of people nodding their heads, right? It's a common refrain in the CAM world. How can you rigorously study what I do? Everyone's an individual. Versus, and I think many of the researchers in this room would agree, the general mantra of fine, study alternative therapies, but use rigorous standard methods to do that. Look at standard outcomes, use standard study designs, and if there's a signal, you can deduce that. So going back to the study, clinically the question is, does this diet work, right? That's what's relevant to the practitioner and the general sort of public health value of this study. And then going beyond that, how do we know whether it works or not? So the first thing we did was try to figure out the best way to assess that question, how does it work, right? So the first step is we can't use a general population. We'll have to figure out a specific population to look at. And this is where I conferred with the sponsor. Well, where do you hear that your test is most valuable, in what condition, right? So I knew nothing about the test and who uses it. And so the sponsor said, it seems to have, people with IBS seem to do well on diets associated with this. So we narrowed it down to one particular condition, right? So when we ask, what does work mean in general from a clinical perspective, does it mean, do people get better when they eat a diet consistent with the test or not? So then the next question is, how can we best determine whether it, meaning the diet consistent with the test, is efficacious? And certainly we'll look at different study designs. And as we're well aware of, a randomized design will allow us to assess causality as opposed to observational study. And then going beyond that, if it actually works clinically, how does it work clinically? Meaning, let's look at biological mechanisms of this. So we decided to do a randomized controlled trial with the mechanistic component to answer the question, does this work, and if so, how? Right? So then the next challenge was to define the control, because it's not good enough to say, does this work? We have to have a comparator. And in something like this, where everyone's getting an individualized diet, we had to be really careful to choose an appropriate comparator. And we had many different options. So one option was comparing it to usual care, meaning people just getting whatever they were doing for their IBS. But we thought that wasn't an ideal comparator because there's too many confounders. People stress exacerbates symptoms, people travel exacerbates symptoms, people, if there's a food involved and they change their diet, et cetera. So there are too many non-specific factors we thought in using a usual care control. We could do what's called a waitlist control, where people are randomized to receive a diet for a period of time while the next group will receive the diet after a short period of time. And that's most useful when diseases are chronic and stable, and IBS symptoms tend to wax and wane over time, so we didn't think that was the best choice. Right, and also, especially knowing Ted Kapchuk's research in this area, placebo and non-specific effects may predominate, especially with IBS symptoms. Right, so then we thought, well, what about a gluten-free diet? Because a lot of people just do this. It's commonly done. There's not a major scientific basis for this, but it has some public health relevance because a lot of people are on gluten-free diets. Right, there's certainly real-world interest, but then the question would be, does a diet consistent with the test work better than a gluten-free diet? And that wasn't really the question we were asking. Another choice was what's called a low FODMAP diet. And this is a diet that has been shown in multiple clinical trials in irritable bowel syndrome to improve symptoms. And FODMAP stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. In general, it's a very restrictive diet. Lots of fruits and vegetables are taken out of the diet, and people do get much better, but in clinical practice, we see it's very hard for people to adhere to this. But then the question would, and this is a standard of care, meaning this is a dietary intervention that has been shown to work in multiple clinical trials in this population. But once again, the question was, we're not asking, is this diet better than low FODMAP diet? We're asking, is this diet valid at all? So then we decided to come up with a sham diet, right? actual control for the diet. And the goal there was to test the test. Does this test have any value in predicting symptom change? Right, so we used a randomized control design. We kept people on the diet for 4 weeks, consistent with other studies in irritable bowel syndrome, where other randomized trials have shown change in symptoms even in 2 weeks. So we wanted a long enough period to be valid, but short enough to really focus on internal validity, because we wanted people really to adhere to this diet. So doing like a 6-month diet or 12-month diet, though it may have more public health value and for long-term outcomes, we're really looking at short-term internal validity right here. And we're assessing people at baseline, after 4 weeks on the diet, and then after 8 weeks. And so we powered the study based on Ted Kapchick's studies on the disclosed placebos, right? And so there's 80% power on the IBS Global Improvement Scale with a sample size of 58 adults, accounting for 25% dropouts. And then we did a concurrent mechanistic study, and this was registered on clinicaltrials.gov in 2014. So this is how we decided to test the test. So everyone at enrollment got their blood drawn, was sent to the sponsor anonymously. Everyone got back. The patients didn't get the readout, our clinical trials manager. So half the people randomized to the intervention diet, would get a diet consistent with test results. So in general, they're asked to avoid the red foods and avoid the orange foods, allow the green foods, and then a full 4-day rotation for mild intolerance. This is exactly, we just asked the manufacturer, what are your standard recommendations for people on this diet? So that's what people get. The people on the comparison diet, what we decided to do is avoid the green foods, allow the red foods and orange foods, and then a 4-day rotation for mild intolerance. All right, so putting that into practice is a challenge. And so all people were counseled by a blinded registered dietitian in person, over the phone over 2 days, and then 2 weeks later to assess adherence. And so creating the sham diet took a little bit of homework. So what we did was create a food substitution list prior to randomization, such that if you look on the left, does this work, right? So these are the foods. If these showed up in the red category, we would substitute, so a nut for a nut, a vegetable for a vegetable, a common food for a sweetener for a sweetener, et cetera. And we had primary substitution, secondary, tertiary. And so if this was their red food, it would be substituted this. But if this was also in one of the intolerant categories, we'd substitute for this. And so we went on, and we created this list. And so everyone was blinded in the course of the study except our clinical trials manager, who did the dietary assignment. So the dietitian was sent a list of foods to eliminate, and that's it for every patient. So they did not see the multicolored readouts or anything, just these are the foods that the patient needs to be counseled to eliminate. Right, so we had other controls for bias. So all of the testing was sent to the manufacturer anonymously. They certainly were not aware who was in the control group, and I wasn't, or any of the investigators were. All the participants were assessed individually, meaning we didn't have groups. They all came in one at a time. The participants were blinded, as well as the investigators, except for the clinical trials manager who did the food substitutions. All of our data were collected directly into our Encore, which is our electronic clinical trials management system. All of our outcomes and analyses were a priori predetermined, and you can see this on clinical trials. The randomization was only revealed after the trial was finished and the database is locked, and the sponsor, to this day, has no access to the raw data. Right, so going into results of the study, so what we found, on average, people were about 39 years of age, predominantly female, predominantly white, right at the cusp between normal weight and overweight. In general, very similar baseline scores in our outcome measures, and similar distribution of irritable bowel syndrome subtypes, constipation predominant, diarrhea predominant, mixed or undifferentiated. Right, so the trial took place between July 2014 and January 2016. We screened 126 people. 58 ended up enrolling. In general, most people who didn't enroll just didn't meet inclusion criteria. 13 of them declined to participate. Other people had other reasons, just travel and that they didn't want to change their diet and things. So 58 people were randomized. 29 people to the intervention group to get a diet consistent with the test, 29 people to get the sham diet. At the end of the diet, we had no dropouts, and then at the end of 8 weeks, we had 3 dropouts in the intervention group and none in the control group. People were highly adherent. We'd query them at their phone calls and in person. 3 people ate a restricted food 8 or more times during the course of 4 weeks. 8 people ate a restricted food 3 or more times, and 1 person stopped the diet. Everyone else were adherent, as we defined it, to the diet. We used intention to treat analysis with alpha level of 0.05, using independent t-tests to assess between group changes between baseline and week 4, comparing mean changes between groups. We also used Wilcoxon rank sum tests in case the data were non-parametric. Right, so our primary outcome was IBS Global Improvement Scale, right? The same primary outcome used in Ted Kapchik's studies. And so this is a question, and it's asked, compared to the way you felt before you entered the study, have your IBS symptoms over the past 7 days been, and then this Likert scale goes from substantially worse to substantially improved. And what we found in outcomes, so we're looking at change score, so inherently everyone's 0 at baseline. So we're between week 4 and baseline, so at the end of the diet, the green is the comparison diet. So people on the quote-unquote placebo diet improved the average of 1 point on this scale. People on the intervention diet, so the diet consistent with the test, improved about 2 points. And that was statistically significant difference with the effect size of 0.55. And then at 8 weeks, so after the diet ended, that difference was magnified slightly. Right. In the IBS symptom severity scale, another validated instrument to assess IBS symptoms, it's rated on 500-point scale. So looking at the severity of their abdominal pain, how frequently abdominal pain occurs, severity of distension, dissatisfaction with bowel habits, and interference with quality of life. We see the same sort of pattern where the intervention group improved approximately 120 points versus 60 points in the comparison diet, with the differences persisting at week 8. The adequate relief scale was just a single question asking, over the past week, have you had adequate relief of your IBS symptoms? In this case, there were no significant differences between groups, but the pattern reflected the other 2 outcomes where there was more improvement in the intervention compared to the comparison diet. And then the last questionnaire was IBS quality of life questionnaire, which is 34 items looking at how IBS symptoms interfere with their general quality of life. And here the curves really just overlapped in that everyone seemed to get better and minimal difference between the true diet and the sham diet. So what we see here, you can call this the placebo effect or the Hawthorne effect, just the fact of participating in a clinical trial, being monitored. People tend to get better, and especially in TED studies, he's shown that over and over with a variety of interventions or even a lack of intervention. Just the fact of being in a trial can improve IBS symptoms. So that's what we're seeing here and here and here and here. But this delta between the sham diet and the true diet, that's the interesting part, in that we didn't predict that at all, and certainly our hypothesis was that those curves would overlap in every single outcome for every single person. I did think everyone would get better over time just based on knowledge of the placebo literature, but certainly did not expect any differences, let alone statistical significant differences between groups. Right? So we also did, after we finished our primary analyses, we looked for potential confounders or sources of bias. So we looked at the effect of adherence, meaning looking at the people who ate restricted foods versus the people who were highly adherent to the diet to see if there were major differences between groups, but found no major differences. But once again, the whole study sample tended to be highly adherent. So our 50th percentile was people cheating 2 or less times versus people cheating 3 or more times. Perhaps we would have seen a difference if there's a great variation in levels of adherence. We also looked at the effect of the dietitian. So after about 75% of the patients finished the study, our study dietitian went on maternity leave. So we had a second dietitian come in and do the rest of the study, but found no differences in outcomes based on which dietitian counseled them. Right? As noted, we had 3 people drop out of the intervention group, so we imputed null values for them at week 4 and week 8, and then assessed did attrition make a difference, and it didn't in our primary outcomes. Right, so then the other question is, well, maybe this test is just is a way to look at FODMAP foods, so foods that are known to exacerbate IBS symptoms. So what we did is, and this was a very recent analysis, just looked at the most common foods that people actually were told to eliminate in the study. So looking at every single readout for all 58 patients, and we tallied it up. So these were the foods they were asked to eliminate. And this is combined. So the intervention group, the red foods, and the people in the control group, the foods that they were actually asked to take out of their diet. And we saw of the top 15 or so, only 4 of them tended to be high FODMAP foods: almond, apple, onion, and pear. And even with this, this is 21% of the sample we're asked to do. So it was a highly diverse group of foods. And in general, in the test bank, there's 200 or 250 possible foods to eliminate. Right, so then another analysis we did was look at proteomics. So after we finished our initial analyses, we sent out 6 of the high responders, so meaning people who had the greatest response in the IBS SSS, we sent their pre and post blood samples to a commercial company, SomaLogic, which looks at now probably more than 1,200 proteins, but at that time, 128 different proteins. And just shotgun, looking at are there any changes. And what we found was actually one protein in particular, I believe was neutrophil elastase, was significantly changed between pre and post. So these are the people who responded the best to the diet. And the only reason we used 6 people is because this test was really expensive. It was like $1,000 per sample. And then in parallel, we did a mechanistic study. So this was run by my colleague Waj Mihal, who's a gastroenterologist and immunologist in his lab at Yale. So this was done separate. These were different people. These were 20 healthy controls who did not have irritable bowel syndrome. And what we did was the anonymized blood testing on these people. So all 20 people got their blood drawn, and then it came back with the readout. These are the foods they're sensitive to. These are the foods they're not. And then in Waj's lab, he got this specific food extracts and cultured their blood according to manufacturer specifications in his own lab, and looked at changes in these individual patients who did not have IBS, but who had foods that the readout said that they were sensitive to versus the foods that they were not sensitive to. So we're looking at test-positive foods versus test-negative foods, so basically the red foods versus the green foods in an individual. And I'm not a basic scientist, so I can't really interpret it too much, but basically what he found was greater release of DNA in positive foods compared to negative foods, which was statistically significant, but not myeloperoxidase. And the pathways involved were protein kinase C and NF-kappa beta pathways. Also in eosinophils, finding upregulation CD63 cell markers in positive foods versus negative foods, so when exposed to red foods versus when exposed to green foods. And this paper is under review right now as well. So some limitations of our study, certainly we use self-report instruments, but we could counter that by saying that that is standard of care in IBS clinical trials. It was an ethnically homogeneous population, tended to be by and large white females. The diet was based on a single assessment in time at baseline. It was an industry-funded study, and certainly there's a tremendous amount of literature showing that, in general, industry-funded trials tend to be biased to support the sponsor. We did everything possible to limit those biases, but there may be unknown biases. Certainly none of us are consulting or working with the sponsor and did this in an independent manner and had no hypotheses for in support of this. And it was a short duration. It was a 4-week intervention, which has its own limitations. Strengths included using standard measures, rigorous blinding as well as possible as we could. We used intention to treat analysis. We had high adherence and low dropouts in our sample. Our sensitivity analyses corroborated our initial findings. We had mechanistic correlates, and this was all done independently from the sponsor, the design, the conduct, the analysis, as well as the publication. Right, so this is the first study, to our knowledge, to rigorously control for nonspecific effects of an elimination diet associated with a commonly available food sensitivity test. We also note that the sham diet showed some benefit, and lots of data showing that nonspecific contextual and placebo responses tend to be high in irritable bowel syndrome. And it is possible that the comparison group results, so meaning the placebo effects seen in the comparison results, could reflect a combination of not just beneficial placebo effects in terms of being in the study, but it could probably be, there might be some deleterious effects of eating foods that they're, based on this test, that they shouldn't be eating. And we know that diet can affect a number of factors that influence IBS symptoms, including the microbiome, immune activation, intestinal permeability, brain-gut interactions, and GI motility. All of these things affect IBS symptoms. Right, so in conclusion, in this sample, individualized diets based on leukocyte activation testing show greater efficacy compared to a sham diet in IBS symptoms. And combined with our mechanistic studies, the results have implications in understanding pathophysiological mechanisms and the role of food intolerance in irritable bowel syndrome. And also our mechanistic study raised some questions. What is the role of food intolerance in healthy people or people without irritable bowel syndrome? Because those people had some readouts and showed some biological differences between test positive and test negative foods. Future studies in larger samples with a larger duration, other disease states are warranted, both clinical studies and mechanistic studies. So certainly need to acknowledge our study team. Teresa Weiss, our clinical trials manager, Waj Mihal, my co-investigator, the rest of our postdocs and our dietitians and students on our team. The study was funded by Cell Science Systems Corporation, the manufacturer of the test. The sponsor had no role in study design, data collection, data management, analysis, interpretation of data, writing of the report, and a decision to submit the report for publication. We also use resources from our CTSA, the Yale Center for Clinical Investigation, which involves NIH funding. So happy to take any questions at this point.
That was fabulous. Thank you.
Sure. Yeah.
I'm going to try to get this going, so hang on.
What's known about the gut microbiome and IBS, and have you thought that you might take some fecal samples in these two study groups in future studies?
Oh, absolutely. We certainly will in future studies. And I mean, this was a pilot study, and at that time, Waj's lab wasn't equipped for microbiota analysis, but now we're doing multiple microbiota studies, both in his lab and other colleagues' lab who are. But so, yes, absolutely. I mean, the role. I mean, there are a tremendous number of published associations between microbiota composition and IBS symptoms. Diet certainly affects microbiota composition. That could be the mitigating factor, and so the future study certainly will look at that.
Fantastic presentation. So I'm two things I wanted to ask. One is, was the change that you observed the positive change with the data that was given by the lab testing, would that have been sufficient if a pharmaceutical was put in place and they had shown those same results? Would that have been sufficient to have approved the pharmaceutical an agent? Because in IBS, we've had these.
Yeah.
And the second question is, how did out of curiosity, in your offline
Okay, can we do one
discussion?
question at a time?
Okay.
Because my memory is not that good. I have two responses to your first question. I mean, first, I think that's a rhetorical question, and I think certainly this is a small sample of 58 people. And if we showed this in 3,000 people, that would be a huge signal. And if it was a large multi-site phase 3 trial, certainly that would be quite meaningful. On the other hand, this is the unproven, unvalidated intervention, and we've seen that. There's going to be more scrutiny, just based on the lack of data about this intervention.
And I guess that's a follow-up question. How did this company, just as a curiosity, how have they interpreted this data as you've shared it with them?
And they've only seen our interpretation of the data. I mean, certainly they're excited about that.
Mm-hmm.
Yeah.
Thank you, Ather.
Mhm.
I was wondering if you could go back to the slide where you showed the red and the green foods. Yeah. So was it always the case, or usually the case, where there were a lot more foods in the green category than the red category?
Correct. And so the way to control for that is we controlled for the number of foods. So in the intervention diet, so in general, they came to be between like 2 and 10 foods in the red category. So whatever the people in the control group got, if they had 3 foods, then it would be 3 foods from the green. And if they had 10,
not the whole green.
no, it would not. So it would.
Good.
So we
Okay.
controlled for both the rigor of the diet and the
Yeah.
actual content. So every person had an individualized diet, either consistent with the test or systematically inconsistent, but
Thank you.
just as rigorous. So if it was 3 foods, it was 3 foods. If it was 15 foods, it was 15 foods. But everyone got whatever the
Same
true
number
test.
of foods
Yeah,
to deal with.
exactly.
Thanks. Okay.
Get a little geographically diverse and come back.
I was just wondering if there are any implications for having the control group consuming intolerance foods as a whole, either ethically, IRB-wise, or just...
Right. So at our pre-study hypothesis was there would be no difference between groups, and there's no scientific basis even to believe that this test, assesses intolerance. So from that perspective, the IRB thought it not to be a problem. I mean, certainly we did not give foods that people were allergic to, so we screened them. If they had a true allergy, they would not be. But in general, the IRB determined this to be a minimal risk study.
Did you get reports of people having difficulty with the intolerance foods anecdotally with the dietitians?
I can't really answer that because I wasn't doing screening. I mean, I don't know the answer to that.
Arthur, great presentation. Sort of along those lines, I'm wondering if you had any kind of debriefing with subjects afterwards in terms of letting them know what diet they were assigned to and what their real
Right.
food intolerance per
A
this test
handful
was.
of subjects asked for their readouts, and we gave it to them. But otherwise, when we enrolled them, we said, we're enrolling you in a study. We're going to ask you to remove certain foods from your diet. But we didn't tell them anything about the blood test or the technology or whether they're getting a true diet or a sham diet. Everyone had the same consenting that we'll ask you to remove a few foods from your diet for 4 weeks. And so we're most concerned about, will you be able to adhere to this versus true or sham results?
By asking people to remove things from their diet,
Mhm.
just that process in general, how much did their diets change, and did they think that was a tough thing to do?
Well, In some cases, they were asked to eliminate 2 or 3 foods. In some cases, over 15 foods. So in general, it varied from very slight changes in their daily diet to a complete overhaul. And the dietitians worked closely with the patients. I mean, certainly some people didn't stick with it, the ones that ate restricted foods 8 or more times, but that was a minimum. But most people stuck with it because we really emphasize in the screening portion that, can you please do your best to stick to the diet, and it's only 4 weeks. And we had the reminder calls, and the dietitian. It's credit to the dietitians; they were very experienced in elimination diets in general and good at counseling people. And the goal here was internal validity, so we really pushed that. And also, in post-study, many patients said, "Well, I felt better, so of course I stuck with the diet."
So I guess in both groups, are people eating less in general, or are they eating about the same?
Eating about the same. So we didn't do any calorie restriction.
Can I just hop in, because I think it's a really interesting question.
Yeah.
If someone had to modify their diet really significantly with 15 changes versus 2 in both groups,
Right.
do you have an index of that?
We do.
That would be interesting to see, because we know from Ted's work, if you give them 1 pill versus 2, you see a bigger effect. If you give them an injection,
that's great.
It might be just
absolutely.
interpreting the placebo effect.
We can certainly do that.
How drastically do they have to change their lifestyle? People feel like they get something when they make a big change sometimes.
Oh, that's great analysis. It's very easy to do. Number of foods versus change in outcomes.
I think that's a fantastic study. As my understanding, so you made those red food and orange food based on the IgA or IgG.
No, not based on. It was based on this antigen leukocyte activation test. It's another blood test.
Another test. I'm just wondering if you sort of those intolerance food based on IgG.
No.
And I'm just wondering if you have thought, you do some blood test after the.
No, it would certainly be interesting, and that's frankly a major limitation of an industry-funded trial, in that they want you to study their product, not every competitor out there, right? So if we had unrestricted funds or federal funds, we can compare a bunch of different companies, but because it was funded by the sponsor, the point was to study their test.
Regarding the slide I think you just had up, I think that was your sham diet. That one.
Yeah.
That one. I was noticing you have the list of the intolerant food and then the substitutions.
Mm-hmm.
Were there any connections there? Like, for instance, there's egg white at the very bottom.
Mm-hmm.
Tuna is one, but chicken liver goes back to the same chicken. Was that a thought? Did when they were coming up with that diet, was that, how foods are connected, but they're not the same?
Right. So in that case, the thought was just a protein for a protein.
Okay. Nothing more.
Yeah.
Nothing less. There's no other thing.
Yeah.
So eating is often a social activity, and the effect of the society, people that you're eating with, and perhaps an awareness that the participants are on a special diet, that the others who are partaking in the meal or not would make a difference. I wonder if you were able to examine those people who were single and ate alone most of the time versus those who ate in a group to see if there was any difference.
No, we didn't. That would be, we should have. What a great insight. We didn't. But in terms of randomization theory, all of that should be evenly distributed between groups. So we would see those effects in the intervention group and the control group. But no, we didn't look at that, and certainly many things we could do in future studies.
I have a question for you.
Yeah.
It's such a fantastic pilot study, and you really covered every base in terms of dealing with a lot of potential biases. And I know our mentors would say, if you're going to study something, do it really rigorously. If you're going to study something a little bit contentious, really do it rigorously. And I think you did such a fantastic job for this. Now that you have some provocative results, what's your next study?
Well, to look at it in different disease states, to further our mechanistic studies, to look at microbiota. First step, this is under review. I mean, going back to Darshan's thing, it's been rejected from 4 journals now, and it was a really rigorous design and got great comments and feedback, but some of the comments was, well, this isn't a validated test, and my response, well, duh, I mean, that's the point of our study. But, I mean, short term is to publish this, but certainly we do plan to look at it in other disease states. I mean, if this, now it goes back to sort of the industry versus federal funding. If it was NIH funded, the next step would be a much larger study in IBS and in multi-site, et cetera, which certainly we could do, but the sponsor may not be that interested in that.
But I think the typical next step would be to repeat it exactly,
Yeah.
but at a larger scale and maybe add some things. And
Yeah,
I think
absolutely.
in part in response to Darshan's comment earlier on, I think the FDA requires a minimum of 3 positive large-scale trials.
Right.
So after you finished your big one, 2 other people would have to do it for it to be approved.
Right, and we have no commercial interest in this. If the sponsor wants to do that, I mean, that's the route they need to go to for FDA approval.
Are there any other questions?
I'm still wondering about this number of foods. So following up on Peter's,
Yeah.
it's an interesting idea, right? That the more elaborate and drastic an intervention,
Yeah.
the more people are likely to have a stronger placebo effect.
Mhm.
So, but you must have balanced. So okay, so it's just
Theoretically, it should be balanced just based on randomization.
right, because you
Mhm.
randomize this. But
Yeah.
how? I'm still not clear. So you decided. So if you take somebody on the intervention group
Mhm.
and they had a certain number of foods in the red group,
Yeah.
sometimes some of these people had lots of foods in the red group, right?
Mhm.
Then you restricted all of those,
Correct.
or not all of those.
So say you were a participant in a study, and there were a total of 9 foods in the red and orange. Those were the foods you would be restricted.
Yeah, all of them.
If you were the same person, but you were randomized to the control group, it would be 9 foods you would also be restricted, but it would be substituted.
So you matched it.
Matched.
You matched it one-on-one.
Correct.
To each.
Food,
So
yeah.
that piece is not a confounder. I mean, the number of restricted foods was
Was the
equal
exact same,
in between your 2 groups.
no, in between, on the individual level.
Individual, but overall between it must
correct,
have
yeah,
added up,
yeah,
so that you had no difference
Right.
in how many foods were restricted
Right. So
between your two
if a
diets.
person was to restrict 12 foods, they would be restricting 12
Yeah.
foods whether they were in the intervention or the control group. So everyone got an individualized diet.
So you did control for that. So
Yeah.
it wouldn't be, I mean, even if there were a difference in placebo responses according to the number of foods that were restricted, that difference would be balanced across.
It would be balanced, but because this is group level data, this doesn't account for maybe one person had a difference right here, one person had a difference right
True.
here.
So you could still look
and
for
it could be
correlation.
these people
Yep.
up here with higher levels
Individually.
of
That's
food
great.
restriction. Yeah.
So, and one more question. How do you explain how people continue to get better after they stopped
So at this
diet?
point,
I mean, they didn't continue to get better, but they didn't go back to worse.
Right. So at this point, when they came in for their visit, we said, your diet's over and you can eat whatever you want. The people who got symptomatic relief from this diet continued to
they
eat
stayed
what
on.
made them feel better.
Yeah,
So that's what they told us.
that's what they said.
Right.
Very interesting.
Yeah.
Thank you. Great study. I'm just wondering how to implement your results in future clinical practice. There's many diet study. For example, the arthritis study. A lot of people do diet, weight loss.
Yeah.
Later, it's very hard to implement. Just you mentioned individualized.
Right.
How the patient can follow your practice, really implement for their clinical practice, really changing the clinical symptoms.
Well, our goal here was just to assess, does this test have any validity in predicting symptoms in IBS? Not to design a new clinical intervention. I mean, in general, and I have a clinical practice, I have a research practice, and when people come in with IBS, I'm not giving them this blood test. Rather, in our other study, we showed that a mindfulness-based stress reduction intervention helped IBS symptoms, and I think that's a lot more empowering than doing, expensive blood tests. And so I tend to refer people to that. And so, from a research perspective, there's a very narrow question. From a clinical practice, and if this pans out in other trials, then perhaps this can be another clinical option. But fortunately, there are many clinical options, at least in the integrative medicine world, for people with IBS.
Yes, I agree with you. And Peter mentioned about your next step, do large study, right? And eventually, this so main objective it is change clinical practice, right? And so I think
certainly clinical research should change clinical practice, but we had a very narrow question that we asked for this particular study. Was, does this test have validity, both on the clinical side and the mechanistic side?
Last comment.
Mhm.
I just want to make sure we get an announcement before everyone has to leave.
Ather, when you look at the range of
Mhm.
types of clinical tests that
Mhm.
would be used in
Yeah.
this way to inform clinical decision making, what have you learned about the variation of the types of tests? Like, has another company said, well, actually, our testing methodology is better because of this? And has anyone else said to you?
A couple companies
Yeah.
said that, and I said, well, let's study it, and then and we'll do it the exact same way. And are you willing to do that? And
They're not.
so it's credit to the sponsor that they were willing to do that.
So that was a fantastic presentation. Please join me in thanking Dr. Ali.
Thank you. Sure.
Thank you all again for coming, especially with the weather and the parade. I just want to remind you about our next seminar. Again, we're going from research to clinic to research to clinic, which I think is going to work out really well. Our next presentation is actually going to be one of our first presentations from a group that's outside the boundaries of the Harvard Medical School system. It's a group from the New England School of Acupuncture, and they're going to be presenting on acupuncture for trigeminal paresthesia in adolescents. So it's a case study again, and I think it's going to be Maria Broderick and Lisa Comboy's group. Lisa's also has a faculty position at Beth Israel. And then the following month, that's going to be March 7th. The following month, we go back to research, and we have the privilege of having Dr. Chen Wang, who's actually here today scoping things out, and she's going to be talking about a new study that was published in the Annals of Internal Medicine on her work on Tai Chi for knee osteoarthritis. So, and then we go back to clinic, and I think Michelle Dossett's going to be talking about an atrial fibrillation case. So thank you all for coming. We have refreshments. I don't know whether they fit in the right food groups out there. We're working on that. If anyone has a good sponsor for really healthy foods, we'd take it. But thank you again for coming, and please stick around and continue the discussion outside.